Welcome to TrialSite News Podcast Series. Our guest today is Dr. Amanda Lucero. She is located at the Gateway Aesthetic Institute and Laser Center in Salt Lake City, Utah. Dr. Lucero is a naturopathic physician, or ND for short. Her specialties are chronic disease, autoimmune issues, thyroid and cardiovascular disease, women's health, and hormones. We are excited to have her speak to us today about hormones and bioidentical hormones and how they affect the body. So, Dr. Lucero, welcome.
Thank you so much for having me.
Yeah, it's our pleasure. We're excited to have you, and we've got a lot to talk about. Now, before we deep dive into the world of hormones and bioidentical hormones, I'd like our audience to get a bit of a glimpse into the life of Dr. Lucero. Specifically, I noticed that you have an extensive volunteer history which covered AIDS patients and giving aid in Haiti back in 2010. What was the driving force behind giving your time in these situations?
I don't really know. I've just always found myself to be very compassionate towards people in underserved communities, which is ironically not really who I serve, in the present day in terms of my patient demographic. But when I was younger, I felt a big draw toward, caring for those who perhaps did not have the same medical resources or financial resources as others.
How was that experience, especially with Haiti? That had to have been a unique experience going out there, and there was a lot of devastation. What was that like?
It was intense for sure, specifically because I was still in medical school and I was just starting the clinical part, outside of the classroom. So it was one of my first exposures to patient care, which was so interesting because we were working at this clinic and we would encounter patients who were 45 years old. And that was their first encounter with a physician as well, while it was my first encounter with a patient. And the sad part is that a lot of the medical care we gave was just literally feeding these people. There were points when there was a mother of 4 waiting in line who we'd have to tell to come around the back and we'd give her a bowl of rice for her family. So it was very wonderful and uplifting that I was able to be there and help others and, get that clinical training. But the depressing part was that a lot of it wasn't even medicine that I was doing. I was just feeding people.
Which still, though, you're giving your time, helping those who desperately needed it, even if it's just food. That sort of thing matters. That's amazing. And the AIDS patients, what was that like?
That was a very profound experience for me. I did it for about 3 or 4 years when I worked in San Francisco, I lived in San Francisco, and I would always pass by a facility called My Tree that was actually founded by a prostitute turned Buddhist monk.
Oh, wow.
Back in the AIDS epidemic, I believe. I don't know exactly when it was founded. And I used to always walk by it. And one day I saw them actually carrying a body out. And the way that they would do it was this very beautiful Buddhist ritual where they would anoint the body. And, some of these people who were there didn't have any family. So the whole idea, or, a lot of their family or friends had, been taken by the AIDS epidemic. So the whole idea was that no one should have to die alone.
Yeah.
And I made some really profound friendships there. I was often going to a church called Glide in San Francisco, which is really known for its humanitarian efforts, and it's very non-denominational. And, it was just, I would take a lot of the patients there to those services, and it was just a really beautiful experience for me. And I met some really wonderful people with some really cool stories and backgrounds.
That's an amazing story. Thank you so much for sharing that with us today. Now let's go ahead and shift then and deep dive into this hormone conversation. So the first question I have for you today is, what are bioidentical hormones?
So bioidentical hormones are hormones that are given exogenously, meaning outside of the body, in the form of anything from a pellet that's implanted in their gluteal area to a transdermal cream, to a patch, to just a pill, to a sublingual preparation that absorbs under their tongue. And they're the same molecular structure as the hormones that we make in our own bodies. So, they're synthesized in a laboratory, but generally the starting materials are just from soy and yam, kind of yams like sweet potatoes. And they're often labeled as more natural because their raw materials are found in nature. But there's a lot of non-bioidentical hormone therapy that comes from nature too. So for example, Premarin for years was the major hormone replacement therapy in the 60s, 70s, 80s. And, some people are still on it now. And that's actually found in nature as well because it's derived from pregnant horses' urine,
Oh, wow.
mares' urine. Yeah, but it's not, we're not horses, so it's not similar to our molecular structure. And then, there's a lot of confusion about bioidentical hormones, thinking that, oh, they're not FDA approved, but actually some of them are FDA approved.
Huh. Now, why would someone be curious about learning more about these? What symptoms and ailments might prompt looking into this option?
Well, in general, because our life expectancies are getting longer, there's a greater demand for maintaining hormone levels later in life. Because once women go through menopause and men go through andropause, which actually does happen, we usually hear about, women going through menopause and their estrogen and progesterone and testosterone levels dropping. But men go through the male menopause that their testosterone levels dropping. So because people aren't just dying right after this happens, and they have a good at least 30 years later in life to enjoy their lives, they're trying to maintain their longevity. But there's, aside from just post-menopause and post-andropause, there's a lot of other reasons that bioidentical hormones are used. And that's the perimenopausal transition, which is basically the years leading up to menopause. That can be as long as 12 years. Things like infertility, which is unfortunately increasing in infertility rates are increasing in our country. Things like PCOS, which stands for polycystic ovarian syndrome, which is a female disorder in which there's excess male hormones or androgens and insulin resistance, and also resulting infertility. Endometriosis and menstrual cycle irregularities. So there's a lot that hormones can be used in, for sure.
Do we know what brings that on?
It's just the fact that we're probably not, as women, ovulating every month because we're transitioning into menopause. I mean, it's not like, women are regular periods and regular ovulation every month until like the average age of menopause, which is 51, where all of a sudden you just magically don't have a period or ovulate anymore. Unfortunately, it's kind of more of an insidious process.
So it's creeping up on you.
Exactly. And it can be not fun for many.
Gotcha. Now, why are bioidenticals possibly a better option than non-bioidenticals?
Well, I think that it's just common sense to anyone because, like I said earlier, they mimic the molecular structure of our own endogenous or internally made hormones. So they're basically the same thing. But there's also a lot of research supporting bioidentical hormones. For example, I like to cite a 2013 peer-reviewed study, which are like the most reputable studies, that showed really favorable outcomes for transdermal or using topical creams, hormone replacement therapy in the areas of cardiovascular biomarkers, immune function, and overall quality of life. And there's a lot of other studies proving this. And I just find it interesting because unfortunately, all hormones have been grouped into kind of one stereotype as being very dangerous, where that's completely not the case. And most of this comes from a study in the early 2000s called the Women's Health Initiative that looked at a lot of things, but it also looked at hormone replacement therapy. And the overall take-home message that a lot of people got from that study was that hormone replacement therapy increased the rates of stroke, breast cancer, gallbladder issues, and cardiovascular disease. But what's interesting about the study is that a synthetic form of progesterone, which is a predominant female hormone pumped out of our ovaries called progestin, it's completely different from, our own body's structure, progesterone. And they basically, outside of the uterus, have the opposite effect of what progesterone does. And that's really an important point because progesterone is supposed to balance the effects of estrogen to lower the risk of stroke and estrogen-dependent cancers. So progestin that they were given in the study did the exact opposite of this. And that's one of the reasons why, one arm of the study was terminated prematurely. And this kind of dictated, even to this day, a lot of the public's fears about hormones, and not just the consumer, but physicians as well. Another kind of silly point about the study is that the average woman enrolled in this study, their age was at least 63 years, which is kind of, in my opinion, crazy to start someone who hasn't been on hormone replacement therapy at 63 years of age when the average age of menopause is 51 years old. You're supposed to initiate hormone therapy within 5 to 10 years after menopause. So I don't believe that that was very smart on the study's part. What's interesting about this study is that even with, because they did, progestin and estrogen therapy for one study group, and then they did estrogen only therapy. And, you hear all these risks of thrombotic events like strokes happening with estrogen only therapy. But what's interesting is that the increased stroke risk only was present in the patients who were in their 60s. So, that's not to kind of go off on a tangent about that study, but I end up seeing a lot of women in my practice who were not given adequate hormone replacement. Even women who have had a hysterectomy about 20 years ago, a surgical hysterectomy when they were a lot younger, meaning that a radical hysterectomy where they had their not only uterus, but both of their ovaries removed and were not given any hormone replacement at that relatively early age in life. So they basically had what's called a surgical menopause. But because of all these fears, they were not given hormone replacement therapy. So now they come into my office 20 years later with osteoporosis, with increased Alzheimer's risk, with premature aging. They look a lot older than their actual chronologic age. So it's upsetting, to say the least. And in addition to just, you asked me why I find bioidenticals a better option than synthetics or non-bioidenticals can just look at our history. I don't know if you remember DES, which stands for diethylstilbestrol, and it was an estrogen medication that was one of the first synthetic estrogens marketed to mainly treat things like recurring miscarriage and pregnancy complications, but they were also used to manage menopausal symptoms as well. And unfortunately, DES ended up causing vaginal and cervical cancer, breast cancer, infertility, uterine abnormalities, not only in the women who took the drug, but also in their offspring. So that was it's almost like the whole thalidomide issue. That was a big problem, how that was one of the first highly marketed synthetic estrogens. And then the Premarin, the estrogen drug that's derived from pregnant horses' urine, was heavily marketed to women in the 60s. And by that time, at least 12% of postmenopausal women were using this. And progestin, or the synthetic progesterone that I mentioned earlier in that Women's Health Initiative study, that was also being heavily marketed to menopausal females throughout the 60s, 70s, and 80s. And what's funny, but not really funny, kind of sad, is that it was later admitted that all the research directing doctors to heavily prescribe this was funded by a pharmaceutical company called Wyeth Ayers, which I believe was bought out by Pfizer not too long ago, that ended up producing it. So if you want a little chuckle, you can go back and look, and maybe not a chuckle, maybe kind of an eye roll. You can look back at some of the advertisements from the 60s where they were, pushing this drug on people. And the advertisements are silly because they really demonize menopause and just women in general, women who have withdrawn from hormones, and how they absolutely need this drug. So it's really interesting looking at the old advertisements.
Yeah, probably similar to doctors recommending that people smoke.
Yeah, exactly. To keep birth rates down.
Doctor recommended, there you go.
Yeah, exactly.
On the note of doctors recommending cigarettes to everyone, because a pack a day keeps the doctor away, there are conflicting opinions about hormone use. Are they safe or are they not?
Yeah, so I think it's a very case-by-case basis, and it's difficult to make a generalization. I think like with cigarette smoking at this point, you can make a generalization that they are very unsafe. But with hormone replacement therapy, they can be really, really safe and protective in certain situations and increase longevity for the patient, but they can be also very unsafe and risky in others. And that's why it's really important for patients to go to someone who is well trained in this and takes a comprehensive history. Initial visits with me for hormone consult are 90 minutes long in length. And I ask them everything from, if their family or they themselves have a heavy history of breast cancer cancer, or do they have a genetic blood clotting issue, like say factor V Leiden, for example? Do they have a heavy family history of Alzheimer's, dementia, osteoporosis? What is the patient's status in regards to, does she have ovaries? Does she have a uterus? If a man comes to me for testosterone replacement therapy, is he trying to conceive with his partner or wife? That's an important part of it, because that kind of changes the prescription and what I do in regards to that. And also, there's the delivery system of hormones is really important. For example, when you orally take something like estrogen, it has to go through the liver for metabolism, unlike topical or transdermal estrogens or estrogen patches. And this fact can both increase a lot of health risks, but what a lot of people don't know is that it can protect against other health risks, things like Alzheimer's, dementia, or dyslipidemia, increased levels of something called lipoprotein a, that is an independent risk factor for cardiovascular disease, heart attack, and stroke. That's something that can be actually lowered with oral estrogen therapy. So
that's cool.
You have to look at the risks and the benefits, what outweighs what. Even though I really only deal with women's health, I do want to say that there is a lot of misinformation about men's health, especially with the overgeneralization and assumption that testosterone therapy can lead to prostate cancer. I'm probably not the best person to dive into this too much, because a large percentage of my practice are women. But like I said, I do see men. But anyone wanting to look into this subject or interested in it, I would recommend looking into Abraham Morgentaler, MD. I think it's Morgantaleer. He's a Harvard physician, and he does a lot of work on the idea of refuting that testosterone therapy is an automatic risk for prostate cancer. So I think it's fun to look at those articles, because it's kind of a paradigm shift.
Gotcha. Yeah, absolutely. And then for those that are interested, how can patients interested in bioidentical hormones get them?
Well, I think that's a great question. I think it's important to seek out someone who has additional training in hormone replacement therapy. And this is usually a medical doctor who does anti-aging and regenerative medicine, or functional medicine is a big hot word. And functional medicine is basically naturopathic medicine, what I practice. A lot of naturopathic physicians have extensive training in hormone replacement therapy as well. One good thing for patients to do if this is a totally new world for them, or if they've just moved to a different city or something, you can call local compounding pharmacies, because compounding pharmacies commonly prescribe or have these medications prescribed to patients. They have more resources for formulating these medicines. So they usually have a list of physicians that call in and order prescriptions from them a lot.
Gotcha. Now, for hormonal imbalance, how does one test for it?
So like everything else in the hormone world, this is pretty controversial. My personal favorite way of monitoring hormones is by looking at the urinary hormones, and really importantly, their metabolites. I specifically use a test. I'm not paid off by them or endorsed by them or anything, but I just love them. And I've seen such profound results when I treat a patient after running this test on them. It's called the Dutch test, DUTCH, and it's an acronym for Dried Urine Testing for Comprehensive Hormones. And I really like this one because it actually, like I said, looks at the downstream metabolites of things like estrogen, cortisol, testosterone, DHEA, and progesterone. And this is really, really important when looking at estrogen levels in a female and a male, so that we can see if there's risky pathways that the estrogen's going down. So the estrogen can be metabolized through various pathways, and this is part of phase 1 detoxification in the liver. And it's important that it's metabolized down more protective pathways rather than more non-protective pathways, which can bind to DNA and damage it and become very carcinogenic and increase the risk of estrogen-dependent cancers. So that's really important to kind of know where those parent estrogen hormones, E1, E2, and E3, also known as estrone, estradiol, and estriol, what their offspring look like and which pathways their offspring are being metabolized down, so that, we can kind of change that and modify their risk. But there's, like I said, there's pros and cons of each form of hormone testing. People like to use saliva testing. People like to use good old blood testing. And that also kind of depends on like the delivery system of the hormone itself. So if someone is using a patch or a cream or injection or a pill, or a sublingual solution or a pellet implant. For example, sometimes it's a better idea if you're doing transdermal hormones to look at blood levels, because in the urine, they're not going to come up as really high at all. But like I said, still with the urine, you're able to look at the downstream metabolites, which is of the most clinical interest and importance for me.
Very cool. Now, what are some other options to correct hormone imbalance?
Well, I've been mostly talking about reproductive hormones, but alongside with that, I always measure thyroid hormones and adrenal hormones, cortisol and DHEA. Your thyroid gland is that butterfly-shaped gland in your neck. The adrenal glands sit on top of, you got two of them, one each sits on top of your kidneys. And the adrenal hormones are things like cortisol and DHEA, so that I can get the whole picture of what's going on with the patient. Because if I just look at reproductive hormones, there's going to be a big gaping hole in regards to like the patient's health, because those are really, really important pieces of information, because the thyroid hormones, the adrenal hormones, and reproductive hormones all play a really intimate role with one another. There's actually something called the HPA axis, which stands for the hypothalamic pituitary adrenal axis. And that plays a really important role in the reproductive, adrenal, and thyroid system, among other things. And this is basically talking about the hypothalamus and pituitary glands, which are in our brains, and they control our reproductive system, our thyroid, our adrenal hormones, among other things. So the health of these organs in our brain is extremely important. And one thing that's interesting is that hormone imbalance and, dysfunction in all those systems can come from the brain, come from the hypothalamic pituitary axis. And those are kind of like the control centers for our hormones. So if someone's had, for example, multiple traumatic brain injuries from concussions, if they're in sports or anything, that can actually create a hormone imbalance. So that's why having that really comprehensive history. I mean, I even ask my patients, have you hit your head really hard more than once? Because that has implications in hormone balance, which is interesting. But other ways to correct hormone imbalance are just the good old boring foundations of health: having a clean diet, adequate sleep, hydration, exercise, having a good amount of joy in your life. And I'm kind of, like I said earlier, I'm an environmental medicine nerd. And if you deal with hormones as a physician, you cannot ignore that there are so many hormone disruptors in our environment called endocrine disruptors. And they basically bind to our hormone recepting sites and make things go awry. For example, I'm really not a big fan of plastic. I ask my patients about their plastic use, and because BPA, and I know BPA now is not in anything, but it's been replaced with something called BPS, which has been shown to be potentially even more harmful than BPA. And plastic is just laden with chemicals that are those xenoestrogens, and they can be really, really harmful for our health. And people can have estrogen dominance and hormone imbalance just from basically, the foods that they're eating, the personal care products they're using, the air they're breathing. And I don't say that lightly, because Salt Lake City, unfortunately, has some of the worst air quality in the country. So it's really important for the consumer to look into their diet, examine their personal care products, make sure that they're free of parabens, phthalates, plastics, things like that. Make sure they're eating, as little pesticides and clean sources of beef and other meat, so that they're not laden with hormones that the animals are given. These all have major implications in balancing our hormones out.
Right, and diet can play a definite role in that, which then takes me to the next question of autoimmune issues. How does hormones play into these issues?
That's a really good question. I think just from people living longer and just overall stress in our lives and endocrine disruptors from the environment, estrogen dominance is huge these days. Estrogen dominance is huge in that perimenopausal period, which can, like I said, last up to 12 years prior to menopause. It's huge, in the teenage years. That's why you see girls getting their periods earlier and earlier and develop breasts earlier and earlier. This is likely in part due to all the xenoestrogens in the environment, which can kind of make a woman's estrogen to progesterone ratio wonky. And current research is actually linking estrogen dominance to inflammatory processes in the body, including autoimmunity. So I think, that's a great question, because it's important to look at hormone balance when you're dealing with any autoimmune patient. And I doubt most rheumatologists are looking at that, I have to say. And another thing is just stress plays a huge role in inflammation and hormone balance. So cortisol is our major stress hormone, like I said, secreted from our adrenal glands. In this day and age where we have either excessive cortisol, inadequate cortisol, cortisol has its own circadian rhythm. So it's supposed to kind of ebb and flow throughout the day. There's a specific pattern that it's supposed to look like. Mm-hmm. And a lot of people have this totally turned on its head and disrupted. And a lot of that comes from, the blue light from iPhones or any smartphones and computers and just all the screens. So our circadian rhythms are kind of wonky, and that plays into our melatonin output from our pineal gland. But like I said, also our circadian cortisol rhythm. And when we just have so much cortisol being flooded into our system, our cells can become really resistant to it. And cortisol works as a steroid. It's basically like prednisone or hydrocortisone that are sold as prescriptions. Mm-hmm. That's basically trying to mimic our body's production of cortisol.
Oh, yeah. So, people that I know that have lupus that are on prednisone, they call it the devil's tic tac.
Yeah, it's rough. It can make you feel absolutely crazy. And that's very synthetic, but I believe that if our body has excessive cortisol output, it can kind of be like a prednisone picture, a patient being on a prednisone taper or just consistently on prednisone. So like I said, our cells become resistant to cortisol, causes disruption in that HPA axis I mentioned before, and it just makes the immune system become dysregulated, become hypervigilant, kind of attack its own cells, and that's autoimmunity in a nutshell.
Yeah. Now, hormones and blood pressure.
Speaking of cortisol raises your blood pressure. It also raises your blood sugar, and which is an interesting thing to be aware of because 1 in 3 Americans are pre-diabetic. So cortisol can absolutely raise your blood pressure. So if you're constantly in that fight or flight stressed state, your blood pressure, along with your blood sugar, will be high. In terms of like actual reproductive hormones like estrogen, there is some recent research of people, with estrogen dominance developing hypertension, but the mechanism is still unknown. And it's interesting because there's also some evidence that replacing hormones after menopause can lower blood pressure in women, but there's research that shows that it can do the opposite. And I think, indirectly, hormone replacement therapy can really probably help with hypertension, because when women are really, really low in hormones post-menopause, that can cause them to gain weight. And as most of us know, obesity or just being overweight in general can spike your blood pressure. So, sometimes a hormone deficiency or imbalance can indirectly contribute to hypertension in that way.
Well, this has been a highly educational conversation. Thank you so much for joining us today, Dr. Lucero. We really enjoyed having you come on our show today and sharing your knowledge about all things hormonal. And for those of you in the audience curious to learn more about this, and Dr. Amanda Lucero, you can find her at staywellutah.com, or you can connect with her directly at dramandalucero.com and Instagram at Dr. Amanda Lucero. And links will be provided in the description below. And you can also find TrialSite News on Instagram, Twitter, Facebook, and YouTube. The links will be in the description below as well. Thank you again, Dr. Amanda Lucero, for joining us today.
Thank you.
Yeah, it was
Thanks
our pleasure.
for having me.